On behalf of our multi-specialty team, I am presenting our research titled SMAD4 gain-of-function pathogenic variants cause brain and spine anomalies in 40 patients followed in the Myhre Syndrome clinic. We followed 41 patients with Myhre Syndrome who have had molecular confirmation of a SMAD4 pathogenic variant. Key features of Myhre Syndrome are shown on the slide. Many of the external features are illustrated by the two patients shown here. Because little is known about the central nervous system in Myhre Syndrome, the purpose of our study is to determine the frequency of MRI and CT imaging in the head, neck, and spine, to characterize abnormalities as congenital or acquired, and to evaluate whether brain and spine imaging should be part of surveillance. In the future, we plan to evaluate genetic, demographic, and medical factors that might impact the occurrence of abnormalities. We conducted a systematic review of brain, neck, and spine imaging in all of our patients who were enrolled into our IRB protocol. The percentages of patients who had imaging done are shown on the screen. An evaluation of the respective brain MRI, MRA, brain CTA, aorta CTA, and spinal cord MRI for a multitude of congenital and acquired anomalies are shown on the screen. On brain MRI, MRA, we identified that white matter hyperintensities were shown in 36% of our image patients. Vascular abnormalities were seen in 10% of our patients, inner ear anomalies were seen in at least 2 patients, and posterior globe flattening and protrusion of optic nerve heads have been seen in 47% of our image patients. On brain CTA, inner ear anomalies were seen in 25% of our image patients, and a thick calvarium has been seen in at least 2 patients. These images show the white matter hyperintensities as talked about on the previous slide in various locations within the brain. Even though the CTA was performed for the aorta, we discovered several minor skeletal anomalies, including incomplete vertebral segmentation and anastoses in the right thigh. On the spinal cord MRI, transitional tethered cord was seen in 10% of all our 40 patients. However, it was found in 30% of those imaged. We've also found fibrofatty fibular lesion in at least 2 patients, a low-lying conus in at least 1 patient, and sacralization of L5 in at least 4 patients. Because brain and spine imaging in Myhre Syndrome has been inconsistent, the true frequency of many features is unknown. Among the subset of those who had imaging, central nervous system abnormalities were common, seen in about 52%. Underway is additional review of optic nerve abnormalities. In conclusion, Myhre Syndrome causes congenital and acquired anomalies of the central nervous system. Several abnormalities require ongoing clinical radiographic analysis. There is a need to translate the findings of inconsistent imaging into possible surveillance, evidence-based guidelines. But until then, imaging is based on clinical symptoms with a low threshold to image.